Hello, everyone, and welcome to week 8. This mini lecture is going to cover disaster mental health response. All right, so what is a disaster? What exactly are we talking about here in this specific mini lecture? So for this, we're going to talk about an acute, potentially traumatizing event that is collectively experienced and may be natural or human generated. However, I do want to add here that for this mini lecture, we're going to talk about natural disasters, and in the next one, we're going to talk about human generated. And disaster mental health responders are often licensed mental health professionals who either volunteer, usually through Red Cross or other local nonprofit agencies, or they may also contract with them for services that they're paid for to provide mental health services on site after a disaster. And on site might mean in the same area. It doesn't mean at ground zero necessarily of the disaster. It just means in the area that is impacted by the disaster. So a little bit on why you are learning about disaster mental health. One, CACREP says it's important, and you can see standards 3C13 and 2E20 talk about this. So it's important for counselors to know the effects of crises, disasters, stress, grief, and trauma across the lifespan. And it's important for counselors to know about crisis intervention, trauma-informed, community-based, and disaster mental health strategies. And also, I kind of feel like it's hard to find a part of the world, and specifically America, that you live in where you wouldn't experience, or at least be prone to experiencing, some sort of natural disaster. About 400 natural disasters occur every year. And so at some point in your life, the likelihood of being impacted by one, either through primary impact or secondary impact, is pretty likely. It's important to think about how a community may move through a disaster. And so the CDC has something called the phases of disaster model. And it tracks through time the different phases that a community may be going through as they are working through a disaster. And so you can see at the bottom of this picture, it has the time like before the impact, 1 to 3 days in between it, and then up to a couple of years after. Because healing from a natural disaster is not just a quick process. It's not something that we move through either personally or on a community level very quickly. And so often what will happen is right after the impact of the event, you'll have acts of heroism, people being rescued off of rooftops, firefighters who may be fighting a wildfire, and some may fall victim to the wildfire. And so it creates this intense feeling of community, which we could call the honeymoon phase. And if you were around and an adult during 9/11, you may vividly remember that like national honeymoon time after 9/11, and how there was so much cohesion, because I think that the messages we were getting from our government were to band together and have this common enemy. But you see that on smaller scales in lots of communities after a disaster happens. And then what often will happen is disillusionment, because resources aren't provided as quickly as the community needs them. People will start to disagree over how to divide resources. Outside agencies may come in to help, and there may be some conflict between outside and inside sources. So lots of rationale and reasons why it can be difficult after that honeymoon phase. And then as you kind of move into a time where things are looking more stable or beginning to become more stable in the community, there is the time and space to process grief, which is really difficult. So once you're out of the immediate crisis and danger, all of the loss starts to hit home. And so people need lots of support in the aftermath of this. I would say this is usually, a couple months after to years after this coming to terms phase. And so, I think that's one of the areas where mental health professionals that live in the area are going to be most sought out, because people are starting to experience the pain of grief and loss that they may not have been present for previously. And then, of course, you will have anniversary reactions to events. I lived through Hurricane Katrina, and I'll talk about that later. But I still remember, even though that was many years ago now, the date, and I still get pretty nervous around that date, and I still live in a hurricane state, so make that what you will. So, and then of course, the hope is that after a time, the community will settle back into what we would call like a new normal. So that's sort of the hope, but it is important to note that once a community has been impacted by a mass disaster, that the triggering events and anniversary reactions can go on for a really long time. So this is another handy chart that the CDC put together, and it talks about the severity of reaction. And you probably remember this from earlier readings on trauma, but the symptoms that one has from a trauma tends to increase as the risk or perceived risk is increased. And so as people have more specific, incidents of trauma, the likelihood of severity, likelihood of symptoms, kind of hanging around for a good while increases. But after a disaster, many people will have mild reactions such as worry, trouble sleeping, feeling upset. And then you'll have some others, like less than the earlier group, but still a good amount of people that will have a moderate reaction to it, which means the symptoms of the many just persist. And there may also be an added feeling of anxiety. And then for a few people, and often the people who had the most primary exposure to the mass trauma will have some severe reactions such as PTSD and depression, and the symptoms that go with that, such as hypervigilance, sleep problems, the inability for the brain to contextualize. So all of those things can still happen in a mass trauma or disaster as well. And in fact, the literature does tell us that disaster survivors have changes to their brain. And so I wanted to just share a little bit of this information with you all, because we may say, well, disaster is a completely different type of trauma. Does our brain respond in the same way? And in many ways it does. It does respond in the same way chemically as it would to like an individual trauma. And so there is a shrinking in the volume in the hippocampus and the orbitofrontal cortex right after the event. But I think kind of the scary part of this is that it can continue shrinking. The hippocampus can continue shrinking in the year after, particularly around, if a person is not in treatment, if they're not learning to differentiate some of their symptoms, the anxiety and depression can just grow instead of getting better. And that also results in changes in both the gray and white matter in your brain. The gray tissue helps process information, so again, the inability to contextualize and put information where it needs to go. And then the white tissue in your brain helps relay sensory information from your body to your brain. And so you'll often see people who may be in shock or still like disassociated from their body, and that's because the white tissue is not working properly. So how do you respond to immediate disaster? Psychological first aid is the most recommended form of treatment for immediately after disaster. So as if you're part of a disaster response team. And it has a good bit of research behind it to show its effectiveness, and it is considered the most important first step of a comprehensive disaster response. And so you do have your training on PFA, so I'm not going to cover that in depth here because that's a 5-hour training, and I trust that you will get what you need out of it. But just know that that is the first step in responding to a disaster. One of the most important parts of psychological first aid, which I did want to point out, are stabilizing techniques. And so things like structured breathing, which we've talked about, grounding activities, and then reality testing through simple questions. This could be things like, tell me your name, You know, what month is it? What year is it? Where do you work? What is your child's name? So things like that that will help also kind of bring the person back into the present and into the here and now with you can be really helpful. And again, you'll learn more about that in your PFA training if you have not done that yet. So as far as disaster intervention goes, what the person will need will often depend on their exposure. And even to take it a step further, it could also depend on how they were doing before the disaster hit, both socioeconomically and mentally. And so this chart I actually like to read from the bottom up because it kind of builds to the most direct exposure. So if you start at the bottom and you're just talking about vicarious exposure, so this could be, you know, a mental health practitioner coming in and helping people impacted by the disaster. So they don't have any like primary concerns related to the disaster. And so their underlying needs are going to be sort of their beliefs that may have been shifted due to this. They're going to need to reduce the cognitive dissonance around the event and maybe the resources that are being provided or the response. But one solid intervention is to provide opportunities to assist others, which of course is what mental health professionals are doing if they are there. But that could also be said for somebody else that was vicariously exposed. And so as you work your way up this chart, you'll see they talk about indirect exposure, all the way up to full direct exposure to the disaster. So kind of front lines type person. If we're going to use maybe the example of a wildfire, this would be a person who, you know, maybe evacuated in time to save their life, but watched their entire house and everything they, you know, own go up in flames. And so what they are going to need most in the beginning is that personal safety and comfort. And so things like basic needs, rescue, shelter, practical assistance, what do they need to get through the next few days? What kind of support can you find for them? And so the more impacted they are, the more concrete support you will need to be able to provide. The less impacted they are, the more you're going to get into things like psychological first aid, things like providing opportunities to kind of go out and interact and help in ways like that. So I think that's a handy chart for just conceptualizing how the needs will be different based on where the person was when the disaster occurred. So what do we need to know about disaster work, right? Because not every counselor is going to work in disaster mental health. However, most of us live in places where disasters may occur. So it is important to know that it's pretty different from traditional mental health. It's not going to be your standard. People come into your office and they talk about the disaster and then they leave and that's it. That's not really how first response to disaster goes. It's a less formal role and it's very directive, which you've learned if you've done your PFA training. So you have to get into the field quickly, you need to be effective, you have to be able to ask direct questions and provide, you know, resources. You need to be good at being on a team because you're not going to have all the answers. And so you will need to coordinate with others and communicate and know what the resources are so that you can give referrals to people that you are trying to help. And then, of course, you also need to monitor your own well-being. If you're doing this work, it can be very, very trying. It can be very tiring. It can be depressing and stressful. I saw that in myself in my work post-Katrina and also in the people that came in from other places. I spent a good bit of time with some of the Red Cross volunteers that came in for mental health, and they also, you know, were not doing great. They were maybe better off than the people that were primarily impacted by the storm, but many of them were also staying in FEMA trailers or even tents. And if you've ever been to New Orleans in August, it's quite hot and humid at that time, and the bugs are bad. So the volunteers had to really monitor their own mental health so that they didn't burn out and that they went home before they burned out. So what is disaster response when we compare it to a traditional practice? Essentially, when we talk about evidence-based interventions, you all have studied your theories, and so you know a little bit about evidence-based interventions, that they are insight-oriented and theoretically diverse, but they're also have that foundation of an ongoing therapeutic relationship as the healing factor. And disaster response is very different, right? You're not going to have a lot of time to form relationship. It's about using your psychological first aid skills. It's goal directed, and you're helping your clients find insight to move forward in this moment, not long term. So you're not working on, long-term trauma while you're trying to stabilize somebody in the middle of a disaster. The working environment in your traditional practice is probably going to be at some sort of agency or office, or perhaps you'll do home visits. It's certainly not like that in disaster response. You are going wherever you're needed. And so that could be FEMA camps, it could be shelters, it could be schools if people are sleeping in gyms and things like that. So you have to be very flexible and okay with not knowing kind of where your day is going to go. As far as professional activities, I think we kind of covered this already. With traditional practice, you're doing your individual, couple, family, group sessions, you're doing your notes and your administrative work, you're doing some advocacy. But with disaster response, you are working on brief therapeutic interactions, you're trying to stabilize, you're doing grounding. You're probably also going to be handing out food, water, clothes, other things. You may be doing some public education on trauma. I think that's really helpful once you're past the initial phase, is to do some psychoeducation on traumatic reaction so that people know that what they're experiencing is normal, because they might not get it anywhere else. And then referrals and advocacy as well are a really big deal. So the rest of this chart just talks about some of the other differences. This is not a traditional 50-minute session. It's usually less than 10 minutes that you talk to folks. The professional boundaries are much more fluid and not around like relationships. You still shouldn't have sexual relationships with people that you're helping in disaster, but more fluid around, you may actually walk someone to get food in a line. You may be talking within a shelter, so you may not have as much privacy, things like that. And so that's all to be accounted for and is considered pretty normal when you're working disaster response. And then referrals, you have your list at your office that you're probably going to rely on again and again. Hopefully whoever is coordinating the larger disaster response will also have a good list of referrals, but you may also have to do some side work to get those referrals for your clients, because who knows who's going to be impacted and not impacted if it's a large scale disaster. All right, so here are some of the nuances in disaster work that I thought you all might want to just think about. It's really important to adhere to a protocol. That's why I assigned you the psychological first aid training. If something were to go wrong, you want to be able to point to what you were following, what guidelines were you following, what ethics were you following, etc. And part of that is being part of a team and knowing where their direction is coming from, which is the bottom bullet point here. Teamwork is essential because you cannot do all of this by yourself, and also you're not going to know what to do or where you're needed if you're by yourself. It's also really important to have a direct and firm approach while also being supportive, which is not necessarily the approach that you would take in your individual counseling sessions. And know that there is some potential for clients to be aggressive because of the stress they're under. And so, depending on your level of comfort with the potential for aggression, this may or may not be a good fit for you. At the same time, if you're needed and you're called upon and you go, it's also okay to make sure that you tell whoever is handing out duties what you are and are not comfortable with. So if you're not comfortable going out and sitting with people individually, if you might be worried about your safety, they can give you another job. It is important that we talk about the mental health impact on responders for this, and this is not just for you all as mental health professionals, but also lots of people get called in to respond to disasters, and that can be, you know, anyone from EMTs, firefighters, police, it could be National Guard. It could even be like linemen that come in to restore electricity and things like that. And so there is a pretty large mental health impact on responders. We've seen this in the literature probably since like World War II, that responders have mental health symptoms that are from working through with people through the disaster. Sorry, that sounded clunky. So what's interesting is that oftentimes what will be produced is a sort of subclinical symptoms. They'll be similar to the people that you're working with, similar to the primary victims, but may not be to the same extent. But sometimes will look like acute stress, PTSD, or depression. And anyone that works as a responder to a disaster will be at an increased risk for this. I don't know what kind of training they do around this for other people who respond to disasters, but if you know those different factions that I mentioned earlier aren't already doing training, that could be a really good area for psychoeducation in your community. So that's something that you may want to ask about, you know, what training do firefighters get around the mental health aspects and the mental health impacts of working disasters or things like that. Because those are great opportunities to provide services to your community. There's also a risk for burnout and secondary traumatic stress, which I'll cover a little bit more in a bit, so I don't want to say too much about that now. And it's also important to point out that there's a higher attrition rate for mental health volunteers versus you know, more physical based volunteers. And I think that's just because we hold people during their hardest time when they're grieving and they're lost and they're in shock, and it's a lot to carry. And so I think that adds to the importance of us having more responders, more mental health volunteers to do this kind of work, so that there isn't so much load on a few people, you know, so to kind of spread the load out. And you can see that in the CDC's impact pyramid, responders are right in the middle, you know, so we're not sort of up here with individual victims that have high risk, but we're also not down here with the unaffected communities. We're right in the middle. So that is important to remember. I want to talk about just for a moment sort of the types of trauma that could happen with a disaster, and I'll talk a little bit more about this when I talk about man-made disasters as well. But if we start at the bottom, a primary trauma is a personal trauma that happens from an incident. It could also be personal trauma that happens as part of like a mass trauma. So, you know, if you are in a town where a wildfire kind of takes over and burns many areas, and your area, your house was affected, you're going to have a primary trauma from that. And so will your neighbor, and so will the people across the street. You'll all have your own primary traumas, but you'll also be experiencing this mass trauma at the same time. And then above that, we have vicarious or secondary trauma, which is when we have trauma symptoms that can look very much like PTSD or acute stress. However, we're not primarily affected. So we're essentially our trauma symptoms are a result of working with people who have been traumatized. And then shared trauma can happen when you are impacted as on the primary trauma level, but you're also impacted on the vicarious and secondary trauma level. And so it can make it even more difficult to, as a mental health professional, kind of work through your own stuff and still help people in your community at the same time. And that is the topic of the optional reading that I put in your module for this week. So you're probably wondering at this point, like, why does anybody do this? It sounds terrible. It sounds like, it just burns right through you and you're exhausted and, you might be traumatized and it sounds like it would be really difficult. And it is difficult. The number one challenge of it is the intensity of the work. Long days, often in not great conditions. And it is very non-traditional. I think crisis work, whether it's like being on a crisis team for your school district or a crisis team for your county or city, plus working in crisis work for disasters, it's for people who really enjoy, changing up their workday, having something different to do. People that just feel really called to this type of work, because there is a higher potential for burnout and vicarious traumatization. At the same time, the benefits include feeling like you're helping your community or other communities. It's a very important part of professional service. We know that when people get help, when they're listened to, when they're tended to right after trauma, they're likely going to do better in the long run. So having a part in that can be very professionally satisfying, and I guess like just on a human level too. We feel better when we help people feel better, and so that's an important aspect of disaster work. It's a good way to advocate for the counseling profession because many of the licensed folks who go and help with disaster work are going to be LPCs and licensed mental health counselors and the like. And so it helps people understand that our profession we really do wrap around work with folks. We're not just here for specific issues, or if you have a diagnosis or something like that. We care about people from beginning to end and all the ups and downs in their lives. And then I think it also helps model the role that we play in successful trauma recovery, again, from start to end. And if someone has a positive experience right after a disaster with a counselor, they're much more likely to go to another counselor to get help to continue healing if they find that their symptoms persist. I do think it's important for us to talk about cultural considerations. With disaster work, there are so many cultural considerations. And like I said earlier, as someone who lived in New Orleans and was, towards the middle to end of my master's program at that time, I saw this very clearly in the way that resources were allocated for evacuation, for people who stayed and sheltered at some of the convention center and the Superdome and places like that. And so, I think that it's important to recognize that people can be very vulnerable right after a disaster. They feel like they've lost a lot, if not everything. And so to be very careful of not taking advantage of them in their vulnerability. There's also a lot of just categorical inequality in a response to disasters, so both social and material barriers. What happens is the divides that were already there, the advantages that people already had, and the disadvantages that they had just get exaggerated. And you can watch almost any coverage of a disaster and see that just everywhere. There's so much inequality to how people are offered resources for recovery. And so people with privilege before the disaster will have more resources after the disaster, and vice versa. And so it's very important, if you are part of an agency that's doing outreach after a disaster, to make sure that you target some of those higher needs areas to really help them move through. So how can you get involved? So there are lots of ways. The most obvious that I've talked about is volunteering with the American Red Cross. You do have to be licensed before you can sign up as like a mental health emissary for disaster response. You can also volunteer through FEMA's Community Emergency Response Team and the National Organization for Victim Assistance Crisis Response Team. Many times places will have their own response teams, which I talked a little bit about crisis response teams in an earlier module, but You could talk to your county, lots of times schools will have their own. And it's a great way to get involved and volunteer. And I guess I just can't really understate the importance of people who do this work. All right, that's all for this mini lecture. Thank you so much for hanging around, and make sure you take a break if you're going to dig right into the next lecture right away. Stretch, get some water, and then come back to it. All right.